who has been a key member of this entire team and initiative as we've drawn further for it. And he comes with that kind of passion which has been instilled in him related to, respectful abortion care, which has been driven down to him and his family through generations, beginning with his mother, who had initiated this entire thing and brought him into the fore.
Thank
So
you.
thank you very much, Niranjan. Please start.
Thank you so much, Mr. Ajay Bharadwaj. And at the outset, I would like to thank Dr. Shanta Kumari, our president, who has spearheaded this master trainer course for Dhira MTP in collaboration with WHO. So
I think, Niranjan, we have lost you. It seems we have lost Niranjan. Let me just try to reach him on the phone if it's. Vatsala, is it okay if we can start off with your session, please? Because
Yes,
I'm
sure.
not able to reach Niranjan and it seems to have dropped off.
Yes, sir. I'm ready. We can start.
Yeah, please.
So
Thank you.
thank you for this invitation. I would like to thank our President Foxy, Dr. Shanta Kumari, and the Foxy team for this opportunity. So I'll just start sharing my screen. So I'll be talking about safe abortion updates in technology. Although we know that as far as the methods which are used for safe abortion, medical or surgical, there has not been much change in the technology recently. The last change was when medical abortion was introduced into the country, that is almost like 15 years back. So, but I would be just giving an overview about the existing guidelines, talking about pre-abortion assessment, methods of abortion, medical and surgical. That is what the stress is in this presentation. So WHO has done a lot of work to make abortion safe for women, and they have these guidelines and documents for healthcare providers for medical management of abortion, safe abortion care. Not only that, they have document for policymakers also. So to help, because it's not only important that the healthcare professional should be aware of the methods, but also the systems have to be in place to provide safe abortion to women. So if you look at the last decade, a lot of work has been done by the WHO in reaching these goals. And again, our country also, historic MTP Act amendment in 2021, which has made, which has really taken the women's viewpoint also very carefully. And I think that Dr. Niranjan would be talking about it. So coming to when you are going to provide abortion to a woman. So what is important is pre-abortion care, which basically looks at the woman. You look at the history of the woman, do examination, investigations as required, and see like if she has made up her mind for abortion, or like if she's uncertain, then maybe, counsel her and discuss what she really wants, and then discuss with her the methods available. Let her make a choice, and then explain to her about the methods, the follow-up, the side effects, what she expects will happen when she undergoes the process. And also important is post-abortion care and also contraceptive counseling. So when we talk about pre-abortion assessment and counseling, first of all, history taking is important to know that her parity, to know if she has any medical disorders, any contraindications, or she is high risk, where she should have her abortion at a primary health center, should be referred to a tertiary health center. General physical examination is also important, and also pelvic examination to know the period of gestation, and also if she has any local pathology or infections. Laboratory tests, some are not must, but some are desirable. I would be listing them soon. And decision-making information on abortion procedures and counseling with the talking to the woman so that she can help decide what she wants. So generally, medical abortion is safe for most of the women, and we use it for up to 12 weeks of pregnancy. And but as far as Government of India guidelines, up to 9 weeks of pregnancy, medical abortion methods are to be used. There are certain contraindications for using medical methods. These are anemia. Women who have moderate to severe anemia because they may have a little prolonged bleeding, confirmed or suspected ectopic, undiagnosed adnexal mass. If she has uncontrolled hypertension, heart disease, any other medical disorders, we have to be careful when we're prescribing the drugs, or at what level of healthcare facility she should be managed is also important. Again, mifepristone is a contraindication is if the woman is on systemic steroids. And again, anticoagulant therapies also is a relative contraindication because it may make the woman bleed more in the process of medical abortion. So clinical determination of gestational age by LMP and physical examination is acceptable before prescribing medical abortion. Ultrasound is not mandatory for all women, but there may be conditions where you may require ultrasound. If from history you suspect that she may be having ectopic pregnancy, if she has been bleeding, you want to know whether she has expelled or has a missed abortion, or if you find that an examination, the uterus is bigger than the estimated gestational age by LMP, you find she has some adnexal mass, she has a fibroid uterus, or from a history you suspect that she may be having a sort of a uterine anomaly or a molar pregnancy, any of these, then you may have to think about doing a further investigation and ultrasound. Otherwise, clinical and pelvic examination to estimate gestational age is good enough. Pre-abortion investigations are desirable, but not a prerequisite. So a woman should not be refused abortion services for lack of investigations. And it will also depend on the risk factors the woman has on the physical examination findings. So pregnancy test if pregnancy is unconfirmed, and hemoglobin or hematocrit is also if desirable. And again, our blood group testing and Rh status is desirable because if the woman is Rh negative, we should give anti-D if it is available. Again, testing for HIV is if it is available should be done. And screening for sexually transmitted infection is usually done when you're doing a per speculum and per pelvic examination. Other laboratory tests would depend on her medical history, like kidney function test, liver function test, or other tests. Like as already said, ultrasound is not necessary unless to diagnose other complications of pregnancy like ectopic pregnancy, missed abortion, etc. So pre-abortion counseling, you have to ask her thoughts about terminating the pregnancy, the reason for terminating the pregnancy. Sometimes she may be apprehensive, she may want to terminate, but you have to be supportive, talk to her in a non-directive fashion, counsel her, tell her about the methods, let her make up her mind so that she doesn't have a guilt feeling or she feels bad later. She should be helped to decide whatever she wants to decide, and also same for the method of termination of pregnancy. You have to inform her that abortion is a safe process, because that may be another concern for her, because it may be a risk to her life if she undergoes abortion. But it is important that the abortion should be performed by a trained provider and in a proper place, in a healthcare facility. And also, she should be given a choice of the available methods of abortion, the medical and the surgical methods. And depending on her history and her medical problems, you should make a choice with her. And should also tell her about what the procedure entails. If you're giving her a medical abortion, the number of visits she'll have to have, that she may have prolonged bleeding for a few days. And if she has any complications, she has to come back to the hospital or healthcare facility. And also very important is to provide contraceptive counseling and advice, because she can become pregnant as soon as 14 days after abortion. Again, she would want to know when she can resume her normal activities, including sexual intercourse, and any other follow-up care that needs to be told to her or she may want to know should be provided to her. And again, documentation is very important. So informed written consent and other paperwork, whatever is formality, you have to fill the consent forms, and proper record keeping is important. Even if she's not willing for contraception, she should be provided with abortion services. It is not necessary that we tell her, no, we will not do a medical termination of pregnancy unless you get a copper tip, or you tell us what contraceptive method should be used. It is respectful abortion care. Give her the choice. Don't force things on her, and respect her choices. And again, more important thing we have to tell her is that if medical method of abortion fails, if she's taken mifepristone and misoprostol, then the risk of fetal anomaly in case the pregnancy continues. And after taking mifepristone or misoprostol, if she doesn't abort, she cannot change her mind. She will have to undergo medical surgical abortion, because there's a risk of, depending on the period of gestation, you can either give medical again or a surgical, because there's a risk of fetal anomaly with use of misoprostol in the first trimester. So for abortion, again, less than 12 weeks, we can use mifepristone and misoprostol, although the Government of India recommendation is until 9 weeks only. Mifepristone and misoprostol is a standard treatment. If mifepristone is not available, we may use misoprostol only, because the success rate with mifi and miso is much higher than misoprostol. And the surgical methods of vacuum aspiration are also therefore less than 12 weeks. If it is more than 12 weeks, again, mifepristone and misoprostol is the best option. Misoprostol only is not so effective. And other option is dilatation and evacuation. Dilatation and curettage is not recommended. So we have mainly two methods, medical and surgical methods. Coming to the medical methods, like I said, a combination mifepristone and misoprostol is the best choice, higher success rate. So mifepristone is a drug which is an antiprogestin. So it interferes with continuation of pregnancy. So there is placental separation, decidual necrosis. Also, it causes some amount of cervical priming, and also sensitizes the uterus to misoprostol. So the process, the success rate is higher if you give misoprostol after mifepristone. And then when you give misoprostol, it leads to uterine contraction and expulsion of the products of conception. Misoprostol is very the advantages of using tablet is like it can be used alone or in combination with mifepristone. It's easy to handle and store. It doesn't require to be stored under refrigeration, can be stored on room temperature. It is cheap, and it can be administered with various routes depending on what the patient requires. But the preferred routes will be vaginal and buccal. I'll just discuss why. And it reduces a need for skilled surgical abortion providers, equipment, facilities, sterilization, anesthesia. So it is really useful in low resource settings. So what is the protocol? So day 1, you give mifepristone. And if the woman is Rh negative, then we give anti-D. So 200 milligram is the dose. And on day 3, we give mifepristone after priming with, misoprostol after priming with mifepristone. So on, if it is up to 7 weeks pregnancy, according to the government guidelines, you can give 400 microgram misoprostol. If it is 7 to 9 weeks, and 800 microgram misoprostol, depending on the choice of route, sublingual, buccal, or vaginal. In addition, analgesics like NSAIDs, antiemetics can be offered, and some forms of contraception can be started the day she takes mifepristone, or she should start within 7 days of mifepristone if she wants oral contraceptives. I think that would be covered later, so I will not be talking much about that. And again, a desirable is a follow-up visit after 15 days to confirm that she has completely aborted, and to also check for any complications of abortion like infection, incomplete abortion, etc. And also take that opportunity to offer contraception if not done so. The WHO guidelines are standard. So anytime less than 12 weeks, the dose recommended is mifepristone, 200 milligram orally, followed 24 to 48 hours later by misoprostol, single dose 800 microgram by buccal, pervaginal or sublingual route. Vaginal bleeding usually occurs for 8 to 17 days after medical abortion. And some cases, maybe 4-5% of them, the bleeding may even last up to 30 days. So characteristics of different routes. So oral route is usually not recommended and only recommended up to 7 weeks because of it is less efficacious after that, and also the side effects are more. The buccal and the vaginal routes have similar pharmacokinetics, so they have a slow absorption, a slow peak. It's not a very not an increase in the blood levels drastically as it occurs with oral. So the side effects are less, and it plateaus, and the levels are in the blood for a longer time, almost 60 to 90 minutes. So the side effects are less and the effect is prolonged. So drug availability is there for a longer time, the success is better. And sublingual is usually the pharmacokinetics are similar to oral. So it is very important to the patient, what do you mean by when you say take the tablet by the buccal route or the sublingual route? So for the buccal route, if it is 200 milligram tablets, 2 tablets she'll put between her teeth and the mucosa. Here again, 2 between the teeth and the mucosa. Sublingual is under the tongue. So you can use this picture to explain to the patient how to take the tablets properly if it is buccal or sublingual. If she's comfortable with the vaginal route, she can take vaginally also. So for provision of these services, the services can also be given at primary care level, but there have to be referral systems in place for a higher level facility where if the patient has problem like excessive bleeding, she can be referred for management. So additional services that need to be provided when she comes are counseling, testing for sexually transmitted infections, HIV, psychological, social services. Most of this can be provided at primary healthcare level, but there has to be a linkage service to a higher level healthcare facility to manage the complications if arises. We should provide her iron tablets and any pain medications, and very important, emotional support. You have to be empathetic, sympathetic, talk to her properly to give her that respectful abortion care. Follow-up, routine follow-up is not necessary. Following an uncomplicated medical abortion, if the woman is using a combination of the drugs, because we know the success rate is very high, but if the woman is only using mifepristone for medical abortion, it is desirable to have a follow-up visit 7 to 14 days after the procedure to see if she is completely expelled, which we would know by the history of cramping followed by expulsion of products. Her bleeding would have decreased. And also take this opportunity to ask if she has any complications like persistent bleeding, cramping pain, or she's having pain, but she's not expelled anything. She's having fever. So all these could be pointing towards complications of incomplete abortion, infection, or she could have ectopic pregnancy also. So this follow-up visit is useful in that way to look at the complications and take opportunity again to advise her about contraception, which is very important. So follow-up care I've already highlighted. So we need to know if a woman is completely expelled. History is important. So that I've already said what points to ask in the history. If she had a crampy pain and she expelled product of conception, and after that her bleeding decreases and the pain stops, that most likely she is completely expelled. But if the cramping pain is continuing, she's continuing to bleed, or she's bleeding heavy, that means she may have not expelled. If she's having cramping pain on and off, but she's not expelled anything, she may be having ectopic pregnancy. If she has fever or the bleeding is continuing, she has pain in the lower abdomen, then she may be having infection. So depending on the symptoms, if you think it is incomplete abortion or she has complication, you may do a physical examination and further investigations. Just to summarize, the first visit is important because here you will decide whether she is eligible for medical abortion, medical abortion, and also counsel her. What she estimate the period of gestation, counsel her about the method, what she expects from the method, what are the complications, and how to take the drugs, the number of visits she needs to make. Give her mifepristone anti-D if she's Rh negative. Then she comes back to you after 2 days for misoprostol, which you can give under observation, observe for a few hours and send her home. Most of the women would start the process of abortion within 4 to 6 hours of taking misoprostol tablets. And again, so that is at the 3rd visit. And then again, you tell her that what to expect. She may have bleeding, nausea, vomiting, diarrhea, headache, fever, dizziness are common side effects with misoprostol. So she has to be told about that, what to expect. And we need to give her medication so that she can manage her side effects. Like I told you, if there is no bleeding, especially if the pregnancy is between 9 to 12 weeks, we can give an additional dose of misoprostol. Most of the women will start the process of abortion within 4 to 6 hours after administration. And on the follow-up visit on day 15, again, to know if she's expelled or not, complications, take history for those, examination is required, and contraceptive options given to her. And tell her that she may return immediately, she may return to fertility. So it is important that she starts contraceptive method. Best is to start, advise her in the first visit, because if she's willing to take oral contraceptive pills, she could start within 5 days of taking mifepristone. If she wants injectables, then she can take even on the 3rd visit. And, or if she wants to use, I think that will be covered later, I will not dwell on that. So side effects and complication. So we know like she would have pain. So if she come, like we should not be judgmental to say that ki kya hai, darad nahi hoga, it's okay, it's like a little bit of pain, why are you worried? No, if she is apprehensive, she thinks she'll have pain, give her Brufen, or while you have given her misoprostol, she's there with you in the health facility, make her comfortable. If she is having pain, give her NSAIDs. If she has vomiting, give her antiemetics, she should be comfortable. And again, nausea, vomiting is usually self-limiting, but if she requires antiemetic can be given. Similarly, diarrhea is self-limiting. So if she has a failure, incomplete result, so if she comes back to you and follow up, and if there is failure, then you can either offer her a surgical method or a repeat, give her another dose of misoprostol. If it is incomplete, the bleeding is not heavy, then you can sort of watch and see or give her another dose of misoprostol. If the bleeding is heavy, then it is better to offer a surgical method. Or if she wants a surgical method, because the medical method has failed, she may not want a repeat dose of misoprostol, she can go ahead with a surgical evacuation. Again, for excessive bleeding, so we have to tell the woman if the bleeding is excessive. By that we mean if she is soaking 2 big pads every hour for 2 hours, she should report. So by the time she reports to you, if the bleeding has decreased, you can observe her. If the bleeding is continuing, then you have to see her pulse BP, look for pallor, and examine her. Sometimes the products are just lying in the cervical canal. You can do digital evacuation and the bleeding stops. If it doesn't, then you may have to remove the products of conception using surgical method. And depending on if the patient is hemodynamically unstable, you may have to start IV fluids, arrange for blood, and if need be, refer her to a higher center as required. If the bleeding is not much, then you can use a medical method. Again, another dose of misoprostol can be given. Again, recording and reporting is very important. We should not omit filling all the forms like the consent form, the reporting forms, etc. So coming to the surgical method, so we have vacuum aspiration. It can be used up to 12 weeks of pregnancy, and it is quite safe. We should avoid doing a sharp curettage. So evacuation by surgical method can be done using an electrical vacuum aspiration to which we can attach a Carman's cannula. What is important is you can use cervical priming before surgical evacuation, because you can use oral mifepristone or you can use misoprostol a few hours before the procedure. Mifepristone you can give a day or 2 before the procedure. So it makes the cervical dilatation easier, pain is less, and the risk of perforation is also reduced. Again, when you're doing the procedure, if the woman is anxious, she wants pain relief, you can give pain relief. And also some psychological support, counseling also helps her. But if pain relief is required, you can give her either diazepam, or you can give her local xylocaine paracervical block to decrease the pain. You can give her NSAIDs, and that would help her. So steps of MVA, again, this is a surgical procedure, has to be done under proper asepsis. If you're using the manual vacuum aspirator, so you have to close the valve, create a vacuum, make the patient comfortable under proper asepsis. After cleaning the cervix and the vagina, you may give a paracervical block so that there is less pain, and dilate the cervix. But if you have given her misoprostol before 2 to 3 hours before the procedure, then the os opens, so the dilatation you don't have to do, so the procedure becomes less painful. You insert the cannula just beyond the internal os, and with gentle rotating movements or up and down movements, you aspirate the contents. One has to be careful not to put the cannula too much inside the cavity because of the risk of perforation. So after the procedure is completed, you can release the vacuum and remove the aspirator. How would you know that the uterus is empty? Red or pink foam without tissue comes into the cannula and you have a gritty sensation. And then the cervix grips on the cannula. You should inspect the tissue to see whether you have villi or not, because if you don't see any villi, then you may suspect ectopic pregnancy. If the woman is consenting, willing, you can go ahead with contraceptive methods, either IUCD or sterilization. Again, instrument processing, cleaning, disinfecting is very important to prevent infection. So most of the procedures of medical abortion, you don't have to give prophylactic antibiotics. Post-procedure care, you have to monitor her. For surgical abortion, you have to monitor for any complications and provide management if she has any problem like pain or whatever. She may leave the facility when she feels comfortable. And from your side, when she's like awake and not much in pain, bleeding is normal, you can allow her to go home. Ensure that you have told her all the warning signs when she has to come back for follow-up and what medication she needs to take before leaving the facility. And again, record keeping is important. So we have to document everything in the registers, in the treatment chart, and also give her a proper discharge slip. So aftercare management of abortion complications, incomplete abortion, infection, bleeding, ongoing pregnancy, almost all have been sort of covered earlier when I was talking about medical abortion. Infection, then we have to give antibiotics, and if they're retained products, they have to be evacuated. Contraceptive, again, I mean, you can't not emphasize all the time you are seeing her, because it is very important, contraceptive advice, so that she accepts a method of contraception. And again, assess if she requires any other support or help from you, and follow-up can be advised accordingly. So we have made a lot of progress in improving access to safe abortion. Not much has changed in terms of technology, like I said, except for medical abortion, which we are using again for the last 15 to 20 years. But what we have to change and look at is that we ensure safety and quality of care that we are giving to the woman. I think that is what we need to change and what is more important. And the focus here is on respectful abortion services. Every client should have an opportunity to inform, educate, and equip with proper information on contraceptive and counseling. Thank you. So let us make it safe and respectful. And it is a woman's right. Abortion is legal in India. Thank you.
That was wonderful. Thank you so much, Vatsala.
Thank you.
In the rush to make sure the program continuity is there, we forgot to completely and honorably introduce you. But being kind enough to continue with the session. So thank you so much. And in fact, Vatsala is part of this entire initiative and the theme of RAC that we are trying to drive across the country. And many of you will be knowing of her. If not, then she is one of the senior colleagues and an individual who's been working in this area for the last several years, associated with the AIIMS Delhi. Thank you so much, Vatsala, for being here and being part of this entire initiative. Thank you so much. And we have Niranjan back. Thank you so much, Niranjan, after this little bit of glitch, but please do carry on. Thank you.
Thank you, sir, for all the introduction which you have done, but I would like to first apologize. I don't know, today I have some network issue where even my personal hotspot was unable to connect. I hope you can see my screen now. Mr. Ajay, support. Can you see my screen?
Sir, yes, sir.
Yes, yes.
So thank you so much. First, I would like to thank Dr. Shanta Kumari ma'am for getting this ball rolling for respectful abortion care and MTP, and welcome all of you, the master trainers, where we are going to learn today this module. So you need to go back to your local society and perform these modules and train your gynecologist and obstetrician so that they are much more equipped. So today my topic of module 1 is medical termination of pregnancy, the new amendment act of 2021. But before that, I want to take you through this chart which tells us the total fertility rate. Now there is a national fertility health survey which goes every 5 years, and if you see the left side graph and the bar chart, it tells you that the total fertility rate over a period of 5 years, which last 15 years, you see here where last 25 years there is an urban and a rural divide. The total fertility rate has dropped. What does it mean? The children per woman. So initially 25-30 years back we used to have 3.7 to 3.4 to 2.7 children per woman, which has now averagely dropped to 1.6, 2.1 of a mean of 2. So that's what it means is that the dropping is there. But if you see on the right hand side, many number of our population, both male and female, on the left and the right, that's blue and yellow, there most of the people are there in between the age of 10 to 14 years to about 35 to 39 years. So we have a large younger population, and that is the new India. That is the India which we are seeing, the young India. We are moving towards the next 50 years where this is going to continue. So it is very high. So we need to focus on the reproductive health, that is the comprehensive abortion care and the family planning program, and for which the WHO has defined, and the definition is absolutely confirmed and it is not raw. It says that abortion has to be safe. There is nothing of unsafe or less safe, but it needs to be safe, and it has to be given at a particular center which is recognized by the government or the local appropriate authority, municipal authority, and it has to give a program where it is run by a place which is registered and trained providers with appropriate method. So coming back to this, if you see the chart, the X and Y axis, it tells the number of induced abortion versus the number of millions of abortions which are done, and the medical abortion contributes about 81%, while surgical abortion contributes 14%. And though it is legal and it is safe, you need to look at the facilities which are being given, that is the public and the private, and the government, the municipal hospitals, the rural hospitals, they contribute about 75%, but 25% is also by the private hospitals, nursing homes, corporate hospitals. But if you see the graph which is there on the lower right hand side, there are more than 91%. It's a very big number which is outside the facility of abortion. So we need to tap that, and that amounts to about 12.7 million medication abortions. So we have to understand the journey. It started in 1971, except the state of Jammu and Kashmir. But the amendment journey started just before the COVID, and when the COVID entered in March as a pandemic all over the world, the MTP amendment got passed in the Rajya Sabha, and it took more than 1 year from there onwards to be having the assent of the president, our honorable president, and then it was notified in the official gazette. From that onwards, 6 months passed, and we got the commencement of the notified act. And finally, on 12th of October, the rules of MTP amendment 2021 was published in the official gazette of Bharat Sarkar. So now I will go through one by one what are the amendments. I am very sure all of you are aware of it, and literally me as a professor in a medical college didn't knew few of the features, and this explained me very well. Even though I am a teacher, but still I am a student and I am learning, and I would like to thank that this is a wonderful presentation which has been done by the WHO team and the Foxy team. So if you see the red aspect, which is the red chart on the left hand side, we have only one provider, but on the right hand side now the amendment of 2021, we just need one RMP up to 20 weeks. So initially it was 12, now it has shifted to 20 weeks. That's a very good leverage to increase the number of facilities, number of public sector like PHCs also. So you have only one medical officer, so you don't have to depend on somebody else. Even a one medical officer in a rural setup or in a primary health center in a public sector or a small nursing home can perform this MTP up to 20 weeks, and it's very very reassuring. So now from 12 to 20 weeks where you have required two providers, it has been only confined to 20 to 24 weeks where you require two RMPs. Now we go to the next slide. Now we should understand what is the modification for the vulnerable group of women. So it is permissible beyond 20 weeks when only you have to have a necessary to save the life of this pregnant woman. But now the amended act says that it has to be in a special or vulnerable categories. We'll go through that, and it has been increased up to 24 weeks. So from 20 it has gone to 24 weeks, and further enhancement for birth defects not compatible. So they are not compatible with life on a medical board consensus. So what is the outcome? It becomes much more safer, it much more legalized, it reduces the incidence of criminal abortions, quacks for that matter, and also for women who have undergone some violence or minors etc. can be dealt with this. Now let us understand the birth defects and the congenital anomalies. That's a very grey area and a grey zone. So whenever we have patients coming up to us and it was only up to 20 weeks we had that cutoff point on ultrasound or on the period of gestation, but now it does not apply in cases of pregnancy. The upper limit gestation has been removed. So there is a hope, there is always a sigh of relief which you can see, and it has to be, there is no upper limit, even 32, 34, 35, whatever, whenever the patient comes, but it has to be a substantial fetal abnormalities. The pediatric surgeon or the person who is in charge of dealing this baby after the delivery in a tertiary center should be basically able to not handle this, or it is incompatible and it has to be diagnosed by a medical board. So even though it the upper gestation has been removed and there is a relief for us, but it should have a substantial amount of fetal abnormalities which are not compatible with life. So that improves the access to the safe and legal abortion. And however the fetal anomalies are diagnosed late, the patient has an opportunity to go and basically to the medical board. There is no running around to go to the court, no need to go and take some lawyer and etc. You just have to go to the medical board. So when we are in city of Mumbai, we need to understand that there is something like an appropriate authority which is at F South, and the medical board is constituted in JJ group of hospitals. You need to have referred the patient to this medical board. Now previously it was only a married woman who had to undergo this MTP and she had to produce a husband, but she doesn't require a signature of the husband. She can alone, if she is above 18 years of age or she is less than 18 years of age, with a guardian. But that is a very different issue now. She doesn't have to be married. Even a woman who is undergoing a live-in relationship, or any woman who is unmarried also, or there is a failure of contraception, that can be extended. So it improves further safe and legal abortion for this woman, Indian woman, irrespective of the marriage age. So that is a very heartening to know about this issue, which we come across in our patients day to day when we are dealing with MTP. Now the new clause insertion which is there, basically about the information which we are supposed to keep, it has to be confidential. It has to be sealed in an envelope, and it has to be placed properly in our cupboard, and we don't have to disclose with our identity or the name, but only a number has to be there. So that was what was done in the previous act. Now we have a new insertion where the name and other particulars of this woman has been undergoing termination shall never be revealed. It should not be revealed. It cannot be revealed to anyone. Okay? Unless a person is authorized by law. So it is a police officer who is an IO, or it is a court, or it is a women's commission, or it is a human rights commission, or whatever is there. And it has to be in a time frame which you cannot be forced. It has to be authorized by law, where you have someone, or you have a letter that yes, I want to know. Then only you have a right to open up the name and other particulars. So it is very important. And of course the consent by the guardian is very simplified. So it increases the privacy, the confidentiality, and all these parameters are taken into consideration. Now let us go through the three rules where I said about is the special and vulnerable category of the woman on one side, and the norms for the registered medical practitioner in the middle, and the third is the power and the function of the medical boards. We will go through one by one, and I think I should finish this within the next 3 minutes. So the first is, we had only 4 categories or 5 categories before. Now it has been extended to 7. I'll just enumerate one by one. One is a survivor, MTP, undergoing for a rape victim or an incest, a woman with a pregnancy for a humanitarian setting like a refugee or a pandemic or a disaster or an earthquake, where she has to undergo an MTP which is declared by the government. Well, the marital status has been changed now. She doesn't have to be married. So even if she is married and undergoing a divorce proceedings, or she has unfortunately become a widow during the course of the pregnancy, she has all right to terminate her this pregnancy if given an opportunity. Then women with physical disabilities. Now this is a criteria which has been involved now and added here, but she has to produce a disability certificate that is to be produced through an orthopedic surgeon in a government hospital, and there has to be a major disability which is above 40%. It cannot be just 10%, 5%, 8%, 20%. It has to be a major disability, maybe a loss of arm, maybe inability to walk in spite of an operation being done, and she is pregnant and she cannot handle this baby. So this is to be understood by us. Mentally ill woman who is on a psychotic drug like schizophrenia 395, or she is totally mentally retarded, she cannot manage her unfortunate victim of mental retardation or a cerebral palsy. Minors, where is the 6th clause, and fetal malformations that has a substantial risk and it is incompatible with life in spite of giving birth or delivery by cesarean section. This child is having physical and mental abnormalities to be seriously handicapped. This is the category which we should understand. Well, as we are aware, we should know that the center for the norms for the RMP, he has to be a MBBS doctor or obstetric and gynec houseman of 6 months completed post, or at least having an MS or a DG or a DNB degree, and if this is also not there, but an MBBS degree with practitioner he is been associated with, and has seen about 25 cases and independently managed at least 5 of them in this hospital. So we have, the practitioners can go to the Wadia hospital, to go to Sion hospital. They can go to an institute and get this certification done from the head of the department that yes, I have seen 25 cases. I have independently managed MTP on my own, and of course you have an experience of at least 1 year in a practice of obstetrics and gynecology. So this has to be certified, and this is what is the new thing which we should understand. Well, the medical board is to be done at an institute. So here in Mumbai, we have the Municipal Corporation of Greater Mumbai, where we have got 4 medical colleges, and the Grand Medical College, which is the government. We have a medical board which has been instituted there. Each and every hospital also can have its own medical board. They should be having a constitution of a gynecologist, a pediatrician, and there has to be a radiologist or a sonologist. And if any other member is not available at the point of time of discussion of this particular case, then it can be substituted by the chair. The chair is the head of the department. It has to be the HOD or the acting head of the department of the obstetric and gynecology of that particular institute can also undergo. So what are the powers of the medical board? They have all the right to allow or deny a medical termination of pregnancy beyond 24 weeks of gestation, with due consideration of all these factors, that this MTP is very important for the mental and physical health of this woman, or they have a fetus with severe malformation which is seriously handicapped, and if the birth of this baby occurs, it's going to cause a lot of trauma to this mother. And it is absolutely, in spite of having a pediatric surgeon around you, it is still not been able to have a compatible life. And of course they have all the right to decide or terminate and reject the application as per the the individualization of the cases there. They can also ask some specialist to join in the board of for a particular case. So what does it do? It functions as to examine the woman. If necessary, they can also examine, not only go through the papers or the reports, they can provide an opinion. It has to be in a form D, and it can allow to do a termination or reject or of the request of what the termination has to be done, and that has to be done in 3 days. You cannot just sit on it for 1 or 2 weeks, and you need to, following the decision which has been given to the for the patients and the relative with a form D being advised by the medical board, all the safety precautions should be done, and she has to undergo appropriate counseling. Within the next 5 days of the receipt of this document in the hand, the patient should undergo MTP termination wherever she wants to undergo, where it will be mentioned that she can be referred to KM hospital, JJ hospital, Kama hospital, Sion hospital, wherever she is residing or she is comfortable, or wherever she has been referred from. So this is very important. In addition to this, I would like all of you to go through this WHO guidelines on safe abortions. These are handbooks which are available in 2012, published of a clinical practice handbook. There is 2015 healthcare worker roles in providing safe abortion, medical management of abortion of 2018. They are all available on the website. You can go through this or ask us. We will surely guide you with all these facilities. So in India, abortion is legalized. We are very lucky people. We are still in the our Asian continent, but there are many countries in Europe, in Latin America, and even in USA, or in probably other aspects or other parts of the world. Still, abortion is not legalized. It doesn't have that much amount of safety and the respect which we are giving as obstetrician and the bureaucrats and the government to our women. So it is a very Samartha Bharat, Sampurna Bharat. What does it mean? Safe abortion made available respectfully throughout health system. So I would like to thank all of you once again for a patient hearing, and the forum is open for any questions. I am really sorry that I was delayed today, unfortunately because of my Wi-Fi connection, but somehow it is going on fine. and please pardon me, but I'm open now for any of your questions. Thank you so much, Mr. Ajay, to tolerate me, and of course, Dr. Dhadwal, who was kind enough to start the program with her module and then allow me to present now. Thank you so much. Mr. Ajay?
Hello.
Yes.
Sorry.
Sir, I finished my lecture. Are there any questions for me?
Yeah. My for some reason my whole system froze up, so I just couldn't.
Yes, somehow I don't know, something is
Thank you
wrong
so
today
much.
with the
Thank you
weather
so
happening
much.
around. Yes, I don't know what's gone wrong, but really I'm sorry and made you to keep waiting. Thank
No
you.
worries. Absolutely fine. I would, take this opportunity to open the floor on the chat box in case you have some questions, which we can take
Okay.
on
Can
now,
we ask?
and then move on to the next one. Yeah, please go ahead.
Ajay, Dr. Shobha Gudi here. I just wanted to know from both the speakers, excellent lectures, very informative, Vatsala and Niranjan. I just wanted to ask whether the rules, the regulations, the new forms are in place or not for 20 to 24 weeks extension of the amendment. The new forms are in place.
Yes, the forms are available. There is Form I, Form E, there is Form D. They are all being changed now. You need to go down to the website, or you can also go through the Foxy website. I'm sure Ajay also will be able to help you to get those forms, and you can download it. We have already downloaded it in our hospital, and we are using it.
Yeah,
Thank
I
you.
hope that answers your question. Any other questions that you may have?
Please raise your hand for the reactions. We can see any hands which are raised for even other members of the lectures who have been taken. Is Dr. Dhadwal there? I think she has left, but if there are any questions.
You can address.
Excuse me, can I ask? Hello.
Yes, please.
Hello? I'm Dr. Kalpana from Guwahati. I just had a query, like even for medical termination of pregnancy less than 7 weeks also, do we need to fill up the consent form, C form,
Yes.
even for less than medical
Yes. You have to be, first of all, you have to register your institute. There is one question now by our
already
Dr.
registered?
Lalita Khambapati, Kambampati. I'm sorry. Hello, if I'm a gynecologist in a private hospital, is there any registration for hospital? Yes. Even though you have a private hospital, it is recognized. See, in Mumbai, we have a Bombay Nursing Home Act. Okay. So similarly, there are different acts, probably in other states of India, and you have the hospital registration being done. There is fire NOC. Similarly, you have an MTP center. It needs to be government recognized. You can't just have a hospital and start doing MTP and start filling form C, because there is a form A which is the application, there is form B which is the compliance of all the MTP, from 20 up to 20 weeks, you need to do compliance. For up to 12 weeks, from 12 to 20 weeks, you need to have a operation theater, you need to have a anesthesia machine, boils machine, you need to have an operation theater, you need to have an anesthetist, a staff nurse, and whatever. All the guidelines have to be, the appropriate authority will come and at a particular time and date, and they will inspect and they will certify that yes, you have all the facilities which are available. You have emergency drugs, you have oxytocin, you have methergin, you have say misoprostol injections. There are emergency drugs of for nausea, vomiting when you are doing anesthesia. So there is atropine, there is deriphyllin, you have all the facilities of say a cardiac defibrillator available. So all these things they will come and see, and then they will certify that this place is registered. You need to give your documents, your MS or DGO or DNB, or your documents of the head of the department, or you're certified that you can do blah blah blah. All these things has to be immediately been given to them along with they ask you all these things. So it's
Sir,
not.
sorry to interrupt, sir. So the question, my hospital is certified under our state Andhra Pradesh Arogya Sri. So it is already certified. My question was, I have all the fire and everything. I'm certified according to the government. But for MTP, is there a certain separate? Because
You
I've been
have
trying to
to,
access.
yes, you have to go to the appropriate authority. There is a MOH. We have different wards here. There is a medical officer who is in charge of your area. He will guide you. It is their
Okay, sir.
job. Their job to fulfill the criteria. If you have, there are 26 permissions you require to get a nursing home registered in Mumbai.
Yes, sir.
26 permissions. Okay.
Yes,
So
sir.
I'm really sorry. I can't change this, but one of them, following your nursing home registration, you need to also get your facility. If you are want to give this facility to your patients, you surely can register. And if you are registered nursing home, and if you have a registered MTP center, you have to then perform these procedures. Very simple.
Okay. Okay, sir. Thank you so much, sir.
This is Dr. Manpreet Kaur Patiala to everyone. WHO recommends MMA till 63 days. Dr. Vatsala, we are doing for more than gestation too. And you also said 12 weeks. Please comment rather till 20 weeks. We don't do MMA. That is till 20 weeks. It has to be done by medical abortion. It's only certified till I think 72 days. I think it has been extended now to 90 days. Mr. Ajay. Yes.
I have to get a technical bit on this.
Yes. And then in case of the size of RPOCs and manage, I think this is quite understood. Is MLC mandatory for unmarried women MTP? Now, if this is unmarried woman and if it is less than 18 years, the POXCO Act come into play. But if she is unmarried woman, she has all the right, and above 18 years, she has all the right to go ahead to do her MTP without anyone. She can undergo. There is no MLC required. It's a personal life. It's her choice. She comes in this category. Why you want to go to, and subject her to police case? No need. Can a private hospital have a medical board of its own? I don't think so. It has to be an institute presently. Do we need to make entries of missed abortion in our? This is a very common question been asked many times. Sometimes MTP is written as missed abortion in the register and it is not shown. So I would put it that way. So if you have an ultrasound report or a patient who is having bleeding PV and she has an ultrasound report of missed abortion, it doesn't go into MTP register. MTP is an elective procedure which a patient wants to do. She wants to do. She has come to you. You are not telling her that you do MTP. It is her choice. So it is a missed abortion is probably an emergency situation, or it is an IUFD which has occurred. It has not to be entered into the MTP register. This is what I feel. Thank you, sir.
Jyoti, I don't know, for some reason we are seeing your screen and we are able to make out that you're calling a couple of people. So I don't know.
Who is that?
Question?
Unmarried patients
Sir, I
below
have a question.
Charushila Deshmukh. We are saying Suguno Bangalore. Okay. Okay, this is one hand being raised. I would like to take this question, Dr. Charushila Deshmukh, to everyone. Thank you, sir. How should we go ahead with unmarried patient below 18 years? Unmarried patient, then it comes under POSCO Act. You have to do a police case. You have to inform the police. You need a guardian's consent and all these things, because then they later on say that they have been raped or they have been etc. So we don't want to come into medical legal issues. This has happened in the past also, and doctors have gone in jail. So you have to be very careful with such cases. So we ask Aadhaar card, though it is not mandatory as per MTP Act. As we go to a hotel to book a room, I am asked my ID card, I am asked my passport, I am asked my etc. So I am asking Aadhaar card to all patients, whether she comes for vaginal, abdominal or MTP. I don't care. It's a document which tells me that, it saves me that when my patient had come, she had told me that her age is 18 years,
Above
and
18
the Aadhaar card. That's it. And if later on she alleges on somebody else and somebody did to her, etc., then you are caught. So that time I can show that yes, she has given me this Aadhaar card. Now whether that Aadhaar card is false or true or it is a duplicate, that is not my job.
Absolutely. I fully agree with you.
Sir, I'm taking a lot of time. Is it okay?
Absolutely fine. Absolutely fine. So
how to keep the patient's name confidential? Yes, you need to keep confidential. There are 15 columns. 14 plus 1 now has come. There are 15 columns you need to also maintain, and you need to upload that MTP report every month before a particular date. It varies with the state. In our Maharashtra and Mumbai Corporation, we need to upload it every month online. There is a username and a password been given by the F South. So all these things are there. You cannot just start doing MTP anywhere. In case of malignancy, if she needs termination, should fill the form. Yes, if she is a cancer patient, she wants to undergo say chemotherapy, or she wants to undergo radiotherapy, or she wants to preserve her ovaries for whatever the reasons. Unfortunately, something has cancer has occurred. Maybe she's 30, 35, 40 years of age. You still have to fill that form. There is nothing that cancer patient came. You have to fill the form. You have to fill the form C. How to keep?
You have raised a query. Can I get a recorded version of the talk? Yes. We will be sending the recorded version to everyone who is on the call today.
Madam, Galaxy M331, confidential means in your OPD case paper, you will be always writing her name, etc., etc. Okay, that is fine. But when we are sending the report, when we are sending to the Municipal Corporation of Greater Mumbai, we don't send a name. We write the number 1 oblique month 02, that is February oblique 2021 2022. So in 2022 I had 8 MTPs. So it is 01 oblique 2 2022 02 oblique 2. So it tells you the serial number. Now you need to have, besides the name or the OPD, wherever you write a serial number, and you have to keep an envelope in your cupboard. So it is a confidential, and you are not supposed to disclose it to anybody. Tomorrow a boyfriend comes, tomorrow a lawyer sends you a notice, tomorrow some person alleges that you are in cahoot with them. No, you don't have to bother unless you get an official order from the IO of the police station, or you get a summons to report in a court for a patient's hearing for whatever the case is going on. You are not supposed to disclose it. Nobody can just come in your consulting and ask you, give me this paper, give me that paper. You don't have to be worried about any newspaper journalist coming to you, etc., etc. If MTP patient has Mediclaim, can we give bill and record? Yes, if she wants to claim that amount, yes, you can give. But whether MTP is covered in that Mediclaim, I don't know. That you will have to find out. But they have, if it is covered by their insurance, you have all right. On the discharge slip, you will be writing, Dr. Manpreet Kaur, you will be writing that she has undergone a procedure of MTP with her name, everything. That discharge card is her personal card. It is given by the hospital. there besides that name and details of our OPD or IPD number, you can put in red certain number which you have already kept in that, because the patient can come after 4 years, 5 years. When you open the register, you have that you have that serial number of the red in color or black in color, number 2, number oblique 2, 0 2 oblique 2 2022. So that will help you to trace her details later on. Is husband consent mandatory for MTP? No, it is not mandatory. It is not at all mandatory, but people cheat you. People get somebody else in front of you and tell he is my husband. People get in my OPD, he is my father. People tell that this is my mother. So, but MTP is a procedure. If it is a surgical procedure, you need to have a consent, and that person needs to be waiting outside the operation theatre. For medical abortion also, the person doesn't require anesthesia, but you need one person who gets her. She can come alone. You don't require a husband consent. But in eventuality, if something goes wrong with the medical abortion also patient, you need one person who is accompanying her. She might faint outside your clinic after taking, suppose she is an ectopic pregnancy, you have not done an ultrasound. So all these things you have to understand. In our field of practice, any patient who undergoes a surgery, you need to take a consent, whether it is DNC, MTP, appendicitis or hysterectomy or whatever. Whether it is a minor hysteroscopy or a laparoscopy, consent has to be taken. Now the consent of husband is not required, but whoever brings, that person is the responsible person to be informed about her condition, and also he should be having the knowledge what is happening with the patient, and when the patient is discharged, he should come and take her. Okay.
Yeah, I think with
Thank
that,
you.
we'll just
Sorry.
take the last 2 questions and then bring a session to close. Niranjan, you have been an absolute bundle of knowledge and information. Thank you so much for holding fort and single-handedly addressing everything.
Yes, Dr. Shobha Gudi has said insurance doesn't cover, so that question is all sorted out. One more monthly report in the Karnataka is sent to DHO, has names of MTB patients, but in Mumbai, in Maharashtra, we don't do. That is what we have done. We don't give, because it is as per the MTP Act. You can talk, your association in Karnataka can talk to them, DHO, and put up this point. We had to go to our F South, AFG went, MOGS went. This was a big UN cry 3-4 years back. So we all had to go, and we said we will not send. So all these things have to be discussed individually. And we have to stop mentioning names. Yes, we are supposed to stop in all the states. Thank you so much.
Thank you so much, Niranjan.
Thank you, sir. Sorry to take your time.
No, not at all. It has been absolutely delight to have you and address so many questions.
No, I wanted to share the experiences, because this POSCO and MTP is such a thing, where innocent doctors in the, trying to help our own patients, the patients then, the law troubles us. That is the unfortunate part of it. And, they have come to my mother also. Just one incident, like 1 or 2 incidences, maybe next time I will share, but it's really, the patient then, everything is done, the procedure is done. Then the police comes in the consulting, you have done this procedure, this case is of a rape, the person is in lockup in Arthur Road jail, and we want the details of this. Now this becomes a rape, so where is the products of conception? Because we have thrown that in the bucket, it has gone in the garbage, it has gone to biomedical waste. So all these points have to be cleared. So it should not happen that you are in cahoot with the accused tomorrow, that you have done an MTP. So when you do an MTP, you have to be very careful that you do not touch a minor, and if it is a minor, you have to inform the police, you have to go through the law of the POXOS Act, and you need a guardian and the signature, and that's why we ask Aadhaar card for our own safety.
Absolutely the last question, so Yoga.
Thank you. My hospital is registered till 20 weeks. Do I need to apply for upgrading it to 24 weeks? Right now, you do not. It is it is complied that since the law of the central has changed, it will come now to the state will go to the local authorities, and now the MOH and the DHO, they will decide whether they want to ask again all the MTP registered in their area now to send all the documents and get themselves registered. But it is understood, since the law has changed from 20 to 24 weeks, it is implied that you have to do this and give the facility to your patients. Now you don't require to again re-register for that. That's what I am thinking.
You're absolutely right. In fact, whatever is in the system, if the change has from 20 to 24 weeks, that change, is government gazette, and
Yes.
everybody who's already registered with the wherewithal of 20 weeks automatically gets there till
24 weeks.
Yeah, so for 24 weeks till something actually comes up. So with that,
Thank you.
thank you so much, Niranjan, for being here.
Thank
Archana Verma, are you there? Archana, are you there for the next session? I don't see her. Sampath, you're Sampath,
Yes. Yes, Dr. Ajay, I am here.
You're there. So, okay. So what, I can't see Archana here. Maybe she's got caught up in some kind of an emergency. And maybe then I will take up the topic of the stigma and the saver module, which is critical. Before that, Nafisa, tomorrow's talk is also a repetition, but with different speakers and different audience. And therefore, the kind of questions which will be there may be different and may be interest to you. But you will not attend that. We will send all the 4 or 5 videos that we have recorded over a period of time for all these sessions to each one of you. And you can choose and decide when you have the time to go through the videos and questions as you would like to do. Thank you so much. We were talking in the earlier session, several things related to, the person may come for an abortion, may, say he's the father, or they'll say he's the mother, may not be the mother, may not be the father, may not be the husband, may be the husband. And all of this is stemming from the fact that there is a lot going on in terms of the, the gender stereotyping, or whether you say the gender stigma and, gender related issues, or if you talk in terms of, the stigmatization or offering or not offering a respectful abortion care without being, passing value judgment, or without being sitting on a chair of a high chair, saying that what perhaps, or even thinking about it, that what perhaps the woman did was right or perhaps was not right. And all of that is something which is encompassing the SAVER module, which is safe abortion values.
1 minute. Ours is pre and post abortion counseling.
Sorry?
Pre and post abortion counseling.
That will come after this.
Oh, Archana is there, huh?
No, Archana is not there. I am taking the session.
You are taking, no problem. Thank you. Thank you.
So, safe abortion and values, evidence, respects, and right is what we are talking about in this particular session, because this is absolutely critical for all of us to understand. When we talk of, this module, it is essentially aiming to ensure that we define what respectful abortion care is, and also highlight the norms and stigma which can affect these services, and provide you some kind of resources which you can use and log in yourself and test out your level in terms of your own mental framework or your approach towards what you offer or are not offering as part of the respectful abortion care. The momentum certainly has been created. What we saw in the earlier 2 presentations, the amendment has come about. Off your mic, please, Shailaja. Thank you. The law has changed. Dissemination is what needs to be done, and which is what we are trying to do here through FOXI. Because FOXI, of course, and the members of FOXI are the largest provider base for abortion care. Online training has been fantastic for all of us, because till date we have done about 11 workshops. Today 13, and tomorrow is the 14th one, and we've been able to reach almost about 2,000 FOXians and build up the capacities and through these sessions. Patients definitely do need respect and safety and quality, which are very critical for providing these services. So what is respectful abortion care? It essentially refers to something related to safety, to dignity, to confidentiality, to freedom from harm and mistreatment, and enables an informed choice without being thrust upon or them, and a continuous support during and after all types of abortion is what is qualifying as a respectful abortion care. So there are a lot of words in it, and there is a lot of importance given to each of these words, and which is what we are trying to do, gynecologists, obstetricians, that we are able to do that. So, can you see my slides, please? I'm not too sure.
Yes, sir.
Okay, thank you, Taki.
Yes, sir.
Okay. In simpler terms is, essentially that you as a provider or as a patient is, treated with dignity, empathy. So, which is different from sympathy. Empathy is trying to be one with whom you're talking to, compassion, regardless of your race, gender, religion, socioeconomic status, or your reproductive history, whether it's related to pregnancy, miscarriages, or abortions. As a healthcare professional, it is our duty to listen and support, for which communication is the key. So what are the norms of stigma, and which is what we need to be aware of? And I'll play a small little video here. Bashir, Shriman, who's there in backend? Hello?
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of how influence access of reproductive health and rights? How people experience SRH stigma, impact social norms and stigma have on our actions personally and professionally, and the
Something went wrong there.
impact they have on the actions of others, personally and professionally.
So essentially, stigma and norms kind of perpetuate disrespect and abuse. And there are 7 categories of disrespect and abuse that we are talking about. Essentially, a physical abuse, which could include slapping or intimidating physically, verbal abuse, shouting, screaming, sexual abuse, abuse of power or taking advantage, stigma and discrimination. The next saver videos will talk about that. Failure to meet a professional standards of care, a rapport between women and providers, which needs to be stopped so that there is a confidence build up, there's a trust build up, and the health system conditions and constraints itself all lead up to categories of disrespect and abuse. Right for every woman is something which we need to be cognizant of and take into our account every time, which essentially means freedom from harm and ill treatment, right to information, protection under laws, and which is MTP and POSCO, informed consent and refusal, and respect for choices and preferences, dignity and quality of care are critical as rights of the woman. Right to timely health care and to highest attainable level of healthcare that you can provide is critical, with liberty, autonomy, self-determination, and freedom from coercion are something which are critical for us. WHO defines 12 domains of respectful care, which essentially translate into freedom from harm and mistreatment, maintaining confidentiality, women's dignity, her choices, and soft skills in terms of being empathetic about this whole thing, providing information and seeking an informed consent, access to support, enhancing the quality and the physical environment and the resources which are provided to the woman, providing an equitable abortion care irrespective of the race, religion, caste system that she's coming from, available of a competent and a motivated provider, contraception itself, advice and the commodity, which will be part of the next session that we're going to talk about. And also the last one is related to continuity of care and counseling are critical for the woman. It is time to strengthen the implementation that we have already talked about owing to the change which have been brought about, the change in MTP laws and the rules 2021. One or more provider does have a lot of responsibility related to the counseling, contraception, referral, and compassionate care. And up to 20 weeks of gestation, one RMP, up to 20 to 24, it's 2 RMPs, and beyond 24 is the access to the medical ward. Between 20 to 24, special care needs to be taken by the providers, essentially is because there is a need for sensitivity. And Anita, for some reason, you are doodling on the slides and you can see some lines coming in. Can you please help and not do that? Anita Maheshwari, again, you're doing that. Can you get your finger out of the mouse, please? Thank you. Let's look at what are the guide to avoiding stigmatizing language. These are all Anita, you continue doing it. I don't know.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Ensure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or registered medical practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is product of pregnancy. However, this term is only useful for materials focused on medical purposes of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do require abortions are not consensual individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as
Saileja, for some reason you're not muted. Please, can you mute yourself? Please, Saileja, please.
punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro life implies that those who support legal abortion access are anti life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the three P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support, it is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
I think this has been a very, very interesting thought process which has been put forward, including the languages that we are talking and the language that one can use or one uses and one possibly can use, in order to make sure the right approach to providing the service and an effective communication both are part and parcel of what you're going to do. Here is a WHO, a safe abortion module, and this is something which is part of the entire SAVER toolkit, which is for safe abortion, values, evidence, and rights. There are several sub modules to it also, and which I will share it in the next slide in terms of the links for the same.
No woman should die due to an unsafe abortion, and when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SAVER toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVER has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVER is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
This is a very, very interesting module or a toolkit, which each one of you can pick up any of these links when we share it with you through the slides or through the program itself. And you could do it at your own time to see where you stand with relationship to equipping yourself, engaging yourself, or in terms of what is your value system and how it compares with what is the standard value system that one needs to follow or one needs to understand as we kind of go forward in the service delivery that you're kind of giving to the women of the country. So 1970s was unsafe abortion, 2000, almost 30 years it took, we talk about safe abortion. And now in 2020, we're talking of respectful abortion care, which is, making sure all the elements related to providing that to the woman are indeed taken care of. Now, I'm going to put up some 2 or 3 interesting questions, and I would request each one of you to put in the chat box, what is your response to these questions? The first question is, according to the WHO, restricting access reduces the number of safe abortions. What do you all think? Is it true or is it false? Please put in the chat box. So we have true, 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 true again, true again, true again, true again. Okay. Nitya is the only one who stands out to say it is false. Let us see, Kalpana is also saying false. I think we need to read the question again. According to WHO, restricting access reduces the number of unsafe abortion. I don't think so. That is a true answer. It is a false answer, because restricting access does not reduce the number of unsafe abortion. It is providing a safe environment, both with appropriate methods and a trained person, which reduces the number of safe abortions. So the answer to that question is false. Another one, MTP amendment 20.
Can I say something here, Ajay? Is it okay if I say something?
At the end of it, let me run through it. Leena, you are also doodling quite a bit. Leena, can you stop doodling on the slides, please? MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. Is it true or false? Lot of truths. Okay, this was slightly a trick question. The answer to this is again false. Except, of course, when you're talking of POSCO reporting is still needed, but abortion services should not be denied. And what we are talking about, we need to have a consent, a written consent. It is not required that it should be a parent, it should be a guardian. Yeah, it should be someone who is an adult and which can be verified through the Aadhaar card also in order to protect yourself. Another one, 30-year-old woman recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. What do you think? Yes or no? Perfect. I think a lot of you have got it right. And the answer indeed is no. It is not our responsibility to tell her to continue the pregnancy. She is the one who has to make the choice based on what is her outlook. So India essentially is, we're talking about bringing about a change through respectful and safe abortion care. And need to emphasize that registration and pre-test is the reason why you are here. Post-test and feedback is something which will be shared to you before end of the last module today, which we will be requesting Sampath Kumari to take it over. And we will take in your questions at the end of the last session, Shobha. Is that fine? Yeah, we're running out of time right now. We have another session coming up. Yeah, Sampath Kumari, please do carry on. Thank you so much for joining us today. It's been an absolute pleasure to listen to what you have to say.
Thank you, Ajay sir. It was really wonderful. You are continuously doing the program. Hope this is which 19th. What is the number? Yes. I will share my screen, sir.
Yeah, we can see your screen.
Yes, I'll go to slideshow. Yes. Good evening to all. First of all, I thank Foxy and Ajay for the opportunity. You have been listening to all talks by Dr. Niranjan and Ajay sir and everything about as he told previously in 70s, it was unsafe. Then it became safe abortion. Now we call it as respectful abortion. See, we have heard about the respectful maternity care. Now it is also essential to have the respectful abortion care. It is her right. Patient can decide whatever she wants, whether to continue the pregnancy or whether to abort it. But as he told, we should not scold, or the words he uses very, very important. So if a patient comes for abortion, what we should counsel before, that is pre-abortion counseling, and what we should do with the counseling after the post-abortion. This is my topic. Just 15 minutes. Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So she comes to the trained person whether to know how, what we are going to do. See, now this pre and post abortion counseling, it is an integral part of the comprehensive abortion services. So when a patient comes, we have to ask why she whether if she is a preemie and the patient comes for abortion, means you can give a counseling. See, for a first baby, if you go for abortion, there may be some complications, but in spite of that, she may have some commitments. So she may need the abortion. So in every cases, whatever the patient decides, we have to counsel according to her decision. So we have to tell her what are all the procedures available. So she may not be knowing as a basket of methods available for abortions, and after the post-abortion, what are all the contraceptive methods available, that we have to tell them. Then the woman may need help in decision. So if she is at a confusion, now she has already two baby, and now she has come with the third, and she wanted to continue or not to continue, means we have to tell her the positive points. What will happen if she is going to continue? And if suppose she is having some whether other medical problems, if you go with these abortions, what can happen? All the positive points and the negative points has to be told to the patient. And whatever she decides, we should give respect to her decision and go on the pathway which she wants. Nowadays, all of us, we tell, even during the delivery, we have the birth attendant nearby. So similarly, for this abortion care also, if some spouse is there, he can also be counseled. If he is coming, he can be counseled. If he is not coming, as everyone has telling, there is no necessity for to get the consent from the spouse. If the patient wants to get aborted, means we can do with the procedures. So this is the pre-procedure. Help, ensure help. See, help women decide about termination of pregnancy. See, whether, as everyone was telling, whether married or unmarried, if she wants to go for abortion and if she wants to continue, we have to give all the options. But whenever we go for abortions, as we have to follow the MTP Act, and at the same time, if it is less than 18 years, we have to follow the POCSO Act. Both should not be mixed. POCSO Act is entirely different, MTP Act is entirely different. So as per MTP Act, we have to follow, and we should give the option, and we should give respect to the patient's abortion. But if she has decided, I want to get terminated in spite of counseling, or whether she has come without counseling, she wants to go, means we have to give the methods. As we know, if she is less than 72 days, whether she is in the early pregnancy, we can tell her there are tablets which is available that you can go for medical methods. And if she comes after the completion of 12 weeks, then we have to tell her again the medical, and if anything is failure, you can go for surgical method. Whenever you tell a procedure to the patient, you have to give the complete information. Suppose if you are going for the medical abortions, for example, mifepristone or misoprostol, whatever you are giving, you have to tell her almost you will, all the products will come out 99%, you may go for complete abortion. Sometimes some retained products may be there. That has to be checked with the ultrasound, and that we can give the misoprostol and remote, and if at all needed, you may even go for a surgical abortion. That option, that everything what can is possible, that has to be told to the patient. So that why if it is incomplete and if it is some problem, they may end up in surgical abortions. So, but if you go for surgical abortion also, there is no complications or nothing is dangerous. So you have to ensure her. So first we have to help her to go for abortion, and to help her what is the method she can go, and you should tell what are all the possibilities that can happen with the medical abortion, that can happen with the surgical abortions. Previously, we used to see a lot of perforation cases and everything. Nowadays, with the prostaglandin type of tablets, the misoprostol and everything, nowadays the incidence of perforation has reduced, and nowadays the incidence of septic abortion is also reduced. What we need to now learn is the respectful abortion care. Then once the abortion is over, we have to counsel her. That is the post-abortion, to adopt a contraceptive method. So she has to decide whether she has to go for other baby or whether she doesn't want other baby. So you give her a time and give all methods of contraception. After the abortion, you should not leave her as such itself. You have to ask her to adopt a contraceptive method. It can be a temporary method or it can be a permanent method, depending on the patient's age, depending on the patient's how many children she have, and depending on the patient's physical conditions. We can give them methods, contraceptive methods available, and what she want we can see. Next, again, it comes whenever we go for an abortion. Always you have been discussing, now you heard from Niranjan Chavan also, that they are not mentioning the names, only the numbers. So we have to ensure the privacy and confidentiality. In our hospital also, we send with the numbers only. Now for our purpose, we can have the names, but for the registry and for the case sheets and everything, it is better to have the number itself. So we have to maintain the privacy and confidentiality, and you should not be judgmental. See, now the patient, if she wants to abort the baby, means you cannot go and tell her that you have to continue. As Sir was putting one question, whether she wants after 22 weeks, yes or no. We are not the person to decide. Only she should decide. She should decide. But it is our duty to tell the possibilities of advantages and disadvantages, and the complications and the indications that we can give. And nowadays patients are very clever and they are in a position to decide, and whatever they decide, we should have a good rapport. So establish the rapport. If your patient is going for an abortion, if the patient is not coming, almost all of us will have the phone numbers and the address, and nowadays we are getting even the Aadhaar card. Everyone are going to fill up the forms now, so you can give a call to the patient and see what has happened. And if she's not coming, because we can guide her. And but once the abortion is over, if she's not willing for a contraception, you can give a call after 1 week and call her, and again you can counsel her. Always respectful is one important, and use the simple languages which they can understand. Always we think that patients Google everything and they come for the opinion, and there are some patients, they don't know even a single words. So don't use the medical terms or medical words. Use the language, what they want. Nowadays still the patients are very fond of DNC. Rather than abortion, if you tell DNC, they will understand like that. Whatever the terms, they are familiar. And the local languages, it is better. If it is in Tamil Nadu, you can tell them in Tamil and wherever it is. So with the local languages and the simple languages should be told. And you have to clear the doubts. Even if they ask 3 doubts and the 4 doubts, no one should get irritated, because it is the repetitive patient for us. But for her, that is the first situation. So if she has doubt, it is our duty to clear the doubts. That is respectful abortion care. So if she had asking, some patient will try to irritate us repeatedly asking the same question. But what to do? We have to counsel. such a way. Otherwise, she will go to the some unqualified person and she may end up in problem. Now, as per respectful, they should get a good care with the qualified person and with the respect. So use the simple language and clarify her doubts. And with the all counseling, as I told, if she has mind as fixed with the termination only, I want only termination means, then as I told you, give the procedures. What are all the procedures available? And after the procedure, if they are going for a medical abortion or surgical abortion, tell her the fertility will be normal. So they may be having the doubt. If I go with this method, in future, can I become pregnant? If I go with this method, if I have the copper T, when can I become pregnant and the next time? So you have to tell the what is the return of fertility with the whole procedure, whether it is oral pills or whether it is the medical abortions, whether it is the copper T. The fertility is almost normal. It will become normal within 2 or 3 months itself. So we have to clarify the doubts that fertility can be returned as early as once the abortion procedure. Always we should counsel her not to become pregnant for 6 months, whatever may be the types. Then you should give her the time. So once you have aborted, means what is the contraceptive to accept her? As I told earlier, immediately if she is not accepting, you ask her to come after 1 month. In that time, you ask her to be very careful, and then you give the choices of contraceptive. So as I told, minimum of 6 month gap is needed for each pregnancy. Once they become pregnant and after abortion, if it is 6 months, it will be good for her health. So we have to talk about her health benefits. Once abortion, all of them will ask, once they do the procedure, whether I should be in the bed rest. So it is not at all the bed rest. Nowadays, only 2 or 3 days they are taking leave, and bleeding is also, if it is very complete, and bleeding is also not minimal. Only minimal is that. So we have to talk about the health benefits and the future pregnancy outcomes for the patient who come for the abortions. So 90% of abortion related maternal mortality. See, the maternal mortality with abortions, of this, the 90% can be prevented with the contraception. So we have to talk to the patient about the contraception. See, I will do most of the times the adolescent school counseling. See, we think we should not talk about the contraception to adolescent, but I talk even about contraceptions to adolescent. Adolescent sexually active, they can even go for a copper T device. So it is our duty to talk about the contraceptions. The methods available should be explained to them such that they can have, and so we can avoid the maternal mortality. Our main aim is safe abortion, now respectful abortion. And the maternal mortality should be, as long as with the abortion conduct, it should not be there. If they are following the contraception, it will be a 0. Okay, so that is needed. So this pre-abortion, it has to be started from the first visit. When they come for the first visit itself, as I told the basket, we have to tell about the tablets available, what is the method she can go for abortion, and after the post-abortion, what is the tablet she can take, what is the injection she can have, or a small device. Even the device we can talk about. See, normally when they are not able to hear, they have some hearing aid. That is a small device like that. So we have to explain the way it is a small device which can be used. So that all procedures has to be done. So where the counseling talks about the fertility and help for her the choices, whatever it, method specific counseling. If it is a medical abortion, as I told, so after 15 days, you have to go for an ultrasound and see. See, in this condition, I want to quote one example. See, one of the patients, she went and had the medical abortions. Normally, most of the doctors will do the ultrasound before the medical abortion, and some may not do it. So what happened with that patient? She took the tablets and the bleeding came. But after 3rd day, the patient came with the shock conditions, that is with the pulse query and BP query to the same hospital. And from that hospital, she was referred to the government hospital. Hope everyone would have judged what has happened. See, the sac was not in the uterus. It was in the tubes, ectopic pregnancy. When you are giving the medical abortions, if it is in the ectopic, it will not work out. So these points also we have to tell her. So better you can have the ultrasound before going for the medical abortion. And sometimes there is a possibility of heterotrophic also. This will come, but that pregnancy in the tubes can become a problem. So once you have the patient comes for medical abortion, you have to tell better you have an ultrasound, or once the abortion is over, you have to go for the retained products. So all possibilities of complications also has to be explained to the patient. If the woman, now or not always we used to tell, we do the abortion means you have to go for copper T. If you give the abortion means you have to go for sterilization, temporary method of tubal sterilization. She may accept, but what happened after the abortion procedure is over, she may change her mind and she will tell, I won't go for any contraceptive methods. Even if you refuses any contraceptive methods, please, we have to do the abortions. Rather than going for an unwanted baby, it is better to go for an abortion as her wish. So if the woman is not willing for any contraceptive method, do not refuse MTP. Even whether it is a private setup, whether or it is a government setup, we have to do what she wants. Okay. Then the general guidelines, whatever. Once the abortion procedure is over, for everything before abortion and after abortion, you should have a checklist. Whatever you have, if it is an abortion, as usual, you can, whether it is married or unmarried is not an indication, but you should have a checklist, whether she have a married or whether some attender is with her, whether she is for medical abortion, whether she is for surgical abortion, what complications can happen. If she is an asthmatic patient, what type of drugs will produce complications. So before that, you should have a checklist. And similarly, after the abortion also, whether the abortion is complete. So that only after 1 week, if she is not coming, you call her for a follow-up, and you for that follow-up can confirm us whether the abortion is complete, and you can have the ultrasound, and it is an opportunity to counsel her for a contraceptive method. And in the same times, you can see a little bit of product is there, and if she is not coming, means there may be an infection. It may put to white discharge, and in future it may end up in PID. There are a lot of problems are there. So with the checklist, with the abortion is complete and there is no existing infection before, and now after abortion also no infection. And any injury, nowadays injury to the genital organ is very, very rare with the abortion. But in spite of that, if any problem, as previously we used to go with the uterine sound, the sound itself will be very sharp and it will produce a fundal perforation. Nowadays, it is not so. Most of the time we have the MR cannula, MR syringe, everything is very safe, and the abortion procedure is very safe. You can have the misoprostol on the day of abortions, posterior fornix, you can have about 100 or whatever it is needed, depending on the hospital. So the injury is rare, but we have to verify whether the injury to the genital organs is present. Or before going for the contraceptions, we have all the, when we give the contraception also, we have to rule out there is a chance of fresh pregnancy. Sometimes the patient would have gone, completed the abortion, and she may come back after 3 weeks for contraceptions, like for methods. In that cases and all, you should be very, very careful, and you should see whether she has undergone any fresh pregnancy. So if she is coming later, means we have to confirm the fresh pregnancy, and then only you have to go for the contraception. So checklist is whether it is complete, no, there is no infection is present, no fever, temperature, bleeding, pus, nothing, and there is no injury, everything is normal. And pregnancy is also not, no fresh pregnancy or the same pregnancy continuing. Sometimes, nowadays it has not happened. Previously, when I was doing the duties of my assistant, one of the patients, she told she underwent abortion. But when she came to us, the same pregnancy was continuing. She is telling, I went for abortion, but now still my abdomen is, becoming bigger and bigger. But when we did the scan, what did happen? The same, what she told us abortion, the same pregnancy was continuing. So nowadays, these are all very rare, but we have to confirm before contraception whether it is, she is having a fresh pregnancy. So then comes the post-procedure counseling. This ensures woman has understood precautions and care needed during post-abortion period. What is the care? Mainly about the contraception. Opportunity to counsel for contraception in case not previously accepted. This is the point I told. If the patient is not accepting, give her a call and ask her to come after 1 week. And that time you have to give the contraceptive. Normally, we should not think, if she wants, she can go for even 5 pregnancy or 6 pregnancy. That is not the aim. We should do the counseling. In spite of that, if she want to have the pregnancy, means that is her choice. Now we are talking about only the abortions. So pregnancy, it is her choice. Then reinforces the need for continuing the use of contraceptive method chosen. Whether she says, sometimes now she will tell, I'll go for copper tail. After 1 week, what she will tell, I don't want a copper T. It is will produce some infection. In my next neighbor told that it is produce profuse bleeding. So we have to explain, this is only a small device kept in your uterus. It will not interfere with any of your family life or anything, infection, nothing will be there. So we have to tell the methods what we are advising and what are the positive points. Then the continue, that is as pre-abortions, even the post-abortions, we have to continue the privacy and confidentiality and reassure her if any problems. Now you can have the property insertion. After this, if you have any problem, we can remove it. It doesn't mean that we have to remove it, but we can reassure her. If any problem is there, you come back to me, I will remove it. So if a property is inserted, once if she is around 35 years means it is effective for 5 years, then 40 years. At that age, you can remove this property and go for other property. Then it will 45 years. After that, almost she will go for menopause, and there is no need for permanent method also. So the way we talk, the patient will really accept. The language and respect, again important for everything. So repeat the information about post-procedure care and the danger signs. After the abortions, if she is having the profuse bleeding and if she is having any abdominal pain and not tolerable pain, means ask her to come back. Always when you go for a medical abortion, even if it is in a OP procedure, as you have been listening to the previous speakers, the form has to be filled and you should have a contact with the nearby nursing homes where they are registered for MTP. If any complications, you should give the address, and if any problem, you can come to that hospital and I will come and see the patient. So these are all very, very important. So this is, as I told, post-abortion is appreciate and immediate care, what IUCD or medical abortions to be given, what are all the oral pills it is follow-up, and follow-up protocol, how if it is a OC pills is given, when it is to be taken, almost it is to be taken at the same time. And if she has forgotten, that you could have heard in the previous speakers, one day if she forgot, means the next day she can have the 2 tablets. These are all the basic things that has to be told. And the continuity, the card, you have to give the cards for the patient. Almost they will be having the OPGT. If no card means OPGT is effect. And the anxiety should be relieved, and the couple counseling, if possible, it has to be done. You should also give the emergency contraceptive pills. That is also nowadays available. That has to be done. Usually, even as per POXO Act, EC pills can be given to the adolescent. Repeatedly, I am talking about the adolescent also because I am taking this opportunity for the gynecologist to counsel the adolescents and give treatment for adolescents. So that only I am telling that EC pills also can be given for adolescents. So what are all the contraceptive methods? Just a few slides. See, these are all the methods, barrier methods, condoms in the first trimester. As soon as after the abortions, always counsel her. They should not become pregnant for 6 months. So when they start the sexual activity, condoms can be used, whether it is first trimester or second trimester. So as all of us know, it has no hormones, can be used and easily available. And in every hospital, it is easily available. Most of things, it prevents against the HIV, that is the sexually transmitted infections will be prevented, and enables to even the partner also to take the responsibility for the effect. And next comes next comes that what I told, that device, intrauterine contraceptive device. This after the abortions, when it is in the first trimester, it can be inserted within 12 days, immediately up to 12 days. Nowadays, even after the delivery, whether it is a normal delivery or a cesarean section, we are going for the PPIUCD, that is within 5 minutes. Once the placental, removed placental insertions, we are doing this PPIUCD. So similarly for abortions, you can insert it immediately or up to 12 days. You can give the 12 days property confirmation, confirming that it is a complete abortion. And that is with the medical management. With the medical management, it is inserted around the 15 days, and we have to confirm whether the product of conception is present or not with the ultrasound. And in the second trimester, again, it can be inserted immediately or up to 12 days. Whether first or second, you have to confirm the procedure is complete. How we can confirm? That is only with the ultrasound. We can see there is no retained products of conception and insert the copper T. What are all the additional information is? Copper T is highly effective And as I told, its effect is IUCD 375 and 380 years is for 5 years and 10 years. And with the 2 copper Ts, the patient may go for a menopause itself. And it is an easy procedure. It can be inserted by the MBBS doctors. Now we go for the PPA-UCD training for ANMs, nurses, PHC medical officers, and everyone, the training is given. And it is a easy procedure and one day procedure. If you do it, no need to bother for 5 years. The next month you can ask her to come. Always we should not counsel her, see the thread. Sometimes it may not be seen, sometimes it will be seen. So that has to be, but at least once a year they have to come for a review. There is no hormonal side effect with the copper T. If you go for LNG only, some hormonal, that is different. Now we are talking about only the copper replaced intrauterine device. Then comes the hormones. Whether no hormone effect was there for IUD. With this oral contraceptive pills, there may be some hormone effects, but still, this they can take it daily. Some people, they are very confident and they will take the tablet daily, preferably around 9 to 10 p.m. or whatever it is, within half an hour. Every day they can fix the time and take the tablets. So when it has to be given, it can be given immediately when she is going for medical abortions, means within 3 days, they can go for the OC pills immediately or up to 7 days after abortion using surgical method. And if it is a medical abortion, it can be started on day 3 with the dose of misoprostol or within day 15 of the process of after confirmation of completed abortion. If you have a suspicious that small products will be present, then you can give the misoprostol, can be given in the posterior fornix, and she can go with the OC pills. Or after the 15 days also, you confirm with the ultrasound and then you can start. In the second trimester, again, immediately, if it is a surgical abortion, means immediately or up to 7 days after the abortion. So whether first or second trimester, up to 1 week, we can start within 1 week the oral contraceptive pills and ask her to follow up. She can continue for 1 year or 1.5 years, as long as she wants, she can continue. So what are all the advantages? Nowadays, as all of us know, this oral contraceptive pills, not only for contraception, it regularizes the menstrual cycle. It can be used for endometriosis. It corrects the anemia. And it has positive effects for ovarian carcinoma and disease of fibrocystic disease of the breast and fibroadenomatosis. So these are all, whatever contraceptive methods, tell all about the advantages and also tell about the negative effect. Most of the time that will be not negative, but it may not be suitable for some women whom they are having daily diabetes patient like that. If they have, what are all the disadvantages as per the guidelines, whom they cannot go for the contraceptions can be given. Now again, this oral contraceptive OC pills is a contraceptive pills of estrogen and progesterone. Now they can also go, some people may not be comfortable with taking the tablets daily. In that cases, like they can go for an injection, that is the medroxyprogesterone acetate, which can be taken once in 3 months. That is also an ideal, and the side effect also compared to estrogen, progesterone side effect is less. So you can counsel this also, this if they are comfortable with the injections, they can continue this injections once in 3 months, and if they can continue even for 10 injections. Then what will happen? It will come to 30 months. So when the injection can be taken as like oral contraceptive pills, it is immediately or within 7 days. If it is a medical abortion, start from the 3rd day. Again, if you have a doubt, you go with the misoprostol in the posterior fornix. If a little bit, if it is present also, if you give the misoprostol, it will come out. The patient tells, I won't go for scan, I will be continuing like this one. Means in that cases, you keep a misoprostol and then start the OC pills. Or sorry, now we are talking about the injections. So she can go for the injections and ask her to mention the dates. Give her the card and mention the date today injection is given. So she has to come after 3 months. Give her the date when she has to come. If it is given in the January, February, March and April, she has to come back. So like the pediatric immunization schedule, we can give the card and ask her to come on the particular day. 1 or 2 days missed, it is not going to give any complications. And again, in the second trimester, immediately or up to the 7 days, it can be given. See, it has mentioned as it is highly effective. As I have mentioned, the progesterone is effective. Again, the confidentiality, she can have the injections. Then no need to take the tablets daily. So she can have the injections in the OP and she cannot, no need to inform anyone that she has taken the injection. So again, it can be given by ANMs and it will not interfere with the family life and the quality, no effect on the quality or the breast milk. Even the lactating mother can have this. And as all of us know, that it is a protection for ovarian cancer and deficiency and everything. Again, as like OC pills, again, it is useful, non-contraceptive use for many problems. Then comes the permanent method. So when one post contraceptions, post abortion is over, means we have to give the options of temporary methods. And if she is having 2 children, and if she is having 1 children, and she is no need for other baby, if some patient will die, 1 is enough for me, I don't want the next baby itself. In that cases and all, you can counsel for sterilization. If she is a heart disease or some problem with her, means you can counsel the husband, if at all. Counsel the husband to go for the vasectomy, male sterilization procedure. So this sterilization procedure, depending on, again for this, we can give her the option immediately after the abortions, when she can have within 7 days, or but once immediately once when you are doing, better not to go with the laparoscopic procedure, better to go with the mini lap procedures. So it can be performed after an abortion in the absence of any infections, and you have to confirm before procedure. No infections, no severe blood loss. If her hemoglobin is 6 or 7, you have to correct the anemia, and then only you have to go for a surgical procedure concurrently up to 7 days. Both mini lap and laparoscopic sterilization can be done. As per guidelines, it can be done, whether the mini lap or laparoscopic sterilization. But normally, patient prefers once after the MTP is done, laparoscopic sterilization. Once after the delivery, it is better to go with the open procedure. It depends on the gynecologist's choice and the patient's choice. So as per guidelines, you can go for mini lap or laparoscopic sterilization. With medical abortions, it can, if the patient is going for a medical abortion, that is the mifepristone and misoprostol, means it is better to wait for the next cycle. So whether we can be very confirmed that the abortion is complete, and she can go for the permanent method. So once it is completed, because if you are going to do the medical sterilizations, and if the baby is continuing, means it will be a problem. So wait for the next cycle and then perform the female sterilization with the first trimester. In the second trimester, again with the mini lap sterilization, so again the baby will be of 12 weeks or 13 weeks. So in these cases, once the uterine size is bigger, as I told, for delivery, we don't go with the lap sterilization as per guidelines. Similarly, in the second trimester, you can go for mini lap sterilization up to 7 days. If it is a 14 weeks or 16 weeks, better not to go for lap sterilization, because they may be confident doing the procedure, but there may be an injury to the uterus. Or so as per guidelines, it is not advised laparoscopic sterilization for second trimester abortions done. So what is the advantage? This is, as all of us know, it is a permanent method, but sometimes failure can happen. That has to be explained to the patient. Hope all of us are very well know about the Kanyakumari incident, but still you have to tell her after the permanent, though this may be a permanent procedure, there are some incidences, 2% failure or whatever failure, less than 1% failure is possible for recanalization. So this is a permanent method, highly effective immediately, no interference with the family life, no effect on breastfeeding, no long-term side effect, and protections against the ovarian cancer. So those sterilization is done, and the cancer is not, that is not needed now. So this is a permanent method. Then again with the male method, you can go for the vasectomy. So most of the times our women, our husband may be willing. This woman, she may not be willing for husband's vasectomy. So now again, this trend is changed. Now most of the women, they come with and my wife is I will take her and I will do the surgery of vasectomy. Vasectomy is also very effective and nothing complication. It is a simple procedure, even compared to female sterilization. Male sterilization is a simple procedure, and no need to take rest for any procedures. There is no necessity for bed rest at any time. Whatever method I have told, these are all the contraceptive after the medical methods. OC pills, injections within 3 days up to 15 days. And next comes the contraceptive methods of vacuum aspirations, injections. That is, first is before medical method, 3 days to 15 days. With the vacuum aspirations, up to 7 days, OC pills, injection. Up to 15 days, you can have IUCD, better with the immediately, or up to 15 days. All the same, as far as possible, within a week or maximum of 14 days. So this is what are this technology, what are all the counseling and procedures. This can nowadays we now have that too with the COVID era, all of them have the teleconsultations. So you can give the teleconsultations about the what she wants and the abortion's methods and ask her to come. And you can give the telecounseling also, whatever she want, whatever we are talking in person can be given with the medias, that is with the telecounseling and guidance. Come on first day, you come and have the mifepristone, and after 48 hours come for misoprostol. So the way you have to guide whatever the procedure we are counseling and what she is accepting, for that we have to tell what is the guidance should be present and reference when she has to come to the hospital after the abortion, if she has profuse bleeding, if she is having the abdominal pain, and if she has a very no products is not coming, only slight bleeding is present. In that cases, you can ask with the references, you can tell the hospital where she should have to come. So this technology has now become very what are all the advantages? Patient can avoid the coming from the house, and she can get all messages from the phone itself. These are all the helplines of the website. I think Dr. Shobha Gudi madam is here. That Ask Tanu, that is a very good project done by her. From that, we can ask what are Ask Tanu means, what are all the contraceptive available, what are all the abortions. That is available in the YouTubes, the infographics, the helpline, and education platforms of WHO, MOH, RCOG, and Family Healthcare. Everything, the platforms are patient education platforms are there in hospitals. They have the flyers and everything. So nowadays we can get everything with the recent technological forms. So what are all the advantages or disadvantages with the teleconsultation means the COVID era? Because nowadays even for any fever, everything will come and they will take to the consultation. If it is a COVID means even in the house, no one is touching her. That was the situation for the past 2 years. So she can have everything COVID era with the teleconsultation and approachable throughout the process, and she can have the confidence. So even with the phone also, I can have such whatever the abortion procedure when I can have. Even in the COVID, what we tell, if it is active positive means after the 7 days, you can do all procedures. This is the way we counseled last year. But this year, that is also not at all needed, only 5 days. So awareness, this awareness, spread out questions answered at ease, everything, whatever the question she asks, we can tell through the teleconsultation. Weaknesses, not seeing face to face, because through the phone, we don't know the same patient herself is talking or her attender is talking, that may not be knowing. So that is the face to face. And the demonstration, when she comes means, some people will be having the model of the uterus and the tubes and the ovary on our table. We can explain how the copper T is inserted, through which way it is inserted, and how the pregnancy happens, and how the OC pills prevent the contraception. That can be shown. Demonstration means it is not like demonstrating for all students, it is for a public. A small with a model, we can explain how it is, but it will be lacking with the teleconsultation. So again, privacy and comfort, cost is very less. She cannot no need to travel, and the number of visits is reduced. And only thing is misdiagnosis or misabortion can be there. That if any doubt is present, we should ask her to come out. So everything, there is a positive and the negative effects. If some negative is going means, give her a call and ask her to come to the hospital. So this is the comprehensive abortion care. First assess, confirm the diagnosis and contraceptive need, what is the type of contraceptive she needs, and counseling, video conference. First we are talking about the teleconsultation. Now we have the Zoom platform, video conferences, everything. It can be a combined form, hybrid services and everything. 1 visit, and with the medical abortions, 3 visits. With the COVID era, the media is very, very helpful. So final message is safe abortion care. That is respectful, safe abortion care. So realize the need of the family abortion family planning services, and bring the couple on the board and say for 100% coverage, and whatever the available contraceptive methods has to be told, and scope for the entry, policy, malpractice, service cost and access. As I told, adolescent reproductive health services needs both online and offline. So even for the adolescent, we have to talk about the contraceptions. Hope I have cleared everything. If any questions are present, we can go. I can stop share. Ajay sir. Any questions is there? I don't think any question. Ajay sir. Thank you once again. I thank the organizers for giving me an opportunity. Adolescent less than 18.
And sometimes there is always a gap between what happens at the top and how it trickles down. And therefore, it is important that the dissemination workshops happen at the FOXY level for each one of us to take this process forward and make sure that information is shared and brought to the fore as much as possible. And it is documented and it is well part of the MTP 2021 rules at this point in time. If there's nothing else, Jamuna, could you take over?
Can I ask you a question?
Yes, please.
Sir, can you explain that what you said just now? The consent is not needed.
Yeah, 1 minute. 1 minute.
Sir, in that actually guardian or parent they have removed, sir. They are saying just adult. If the person who is accompanying the girl is, if he is an adult, they need not prove that it is the parent or a guardian. The proof is not.
Basically, see, Kiranmay madam, the definition of guardian is the person who is accompanying the patient is a guardian, not legal guardian. Legal guardian is different. And guardian is different.
If you have any doubt, you can ask. I think Ajay sir is with other Zoom.
Yeah, we need not ask for the legal guardian. Yeah. The person who is accompanying is the guardian, basically.
Yeah.
And once you have to only confirm that he or she is an adult.
Yeah,
I do not prefer PPIUCD.
Thank you.
Yes,
Yeah, I hope that answers the question. Kavita, you have put a very, very difficult question for me here. I couldn't give the pre-test, so I don't know how you're able to join this course here. And there's nothing that I can.
So PPIUCD, Dr. Taru, if you are not preferring means, it doesn't mean you can go for other methods, whatever is available. Jaipur, Qualia, Bangalore Society. Adolescent less than 18 must have a guardian who will give the consent. Please clarify written consent from parents, guardian, or friend. It can be a friend also, but she should be more than 18 years, not only parent or guardian. Okay. Link of registration. Should we do analysis if anyone less than 18 approaches for MTP if they participated in consensual? If it is Dr. Lalita, if it is less than 18 years, definitely as per POXO Act, you have to follow. As I told, POXO Act is different, MTP Act is different. If it is less than 18 years, just to file it, but don't deny to give the treatment. Just to file the case, that's all. You have to give the treatment.
And there was in our master training class, we were told that
that's all, I think.
Eventually update all the list of the medical.
Yeah, thank you so much for holding fort, dear Sampath Kumari. That was an excellent presentation. It had got so much of power and energy which you brought to the whole thing. Thank you so much for doing this for us.
Thank you.
Naisargi, you can submit the post-test right now or after leaving the meeting. Both are fine because the course is complete at this point in time.
Thank you, Ajay sir.
If there's no other question, then
every case, age evidence necessary. Yes, definitely age is important. Less than 18, more than 18. Married or unmarried is not important nowadays. Age is very, very important. With photo ID. Okay, that is Aadhaar card. You can get the Aadhaar card.
We request everyone to be there, please.
Okay, no more questions, sir. Okay.
Okay. If there are no more questions, then I have already posted the, have I posted it, the post test here? Yeah, I have done it. Yeah. So please submit the post test and
Some more.
when you leave the meeting, you will get another pop-up saying that continue and submit post test. If you do it through this link, you need not submit again. But if you haven't missed, if you have missed this link, you can do it again. And in case you can't do it at both the times, there will be a third opportunity. An email will be sent to all the people whose post test is not there. and we will try to do that for you.
Thank you, delegates.
Come on to this.
Yeah, thank you so much, each one of you, for this lovely, availability of each one of you. Please carry this message forward to your society presidents, if you're not already here, and your secretaries or the office bearers, that there is a certain honorarium which is available and will be given to each and every society who is going to conduct this program in the society for its members to share the information and orient the society members. So please request your society members and your society managers.
Please tell to your president and secretaries.
Thank you so much, Dr. Ajay.
Yeah, and this honorarium will be given to each one of each society, and lovely to have each one of you here. All the very best. Have a lovely evening, each one of you.
Thank you.